fantastic commitment to bring robust discussions along the sidelines of World Health Assembly, where sometimes the robustness of discussions is varied with a lot of politics and a lot of aspirations. But here is where we'll get to unpack the real grist of what's happening on the ground. I also want to recognize Carolyn and her team for their contributions to GIDH, the Global Initiative on Digital Health, which really now has been working with countries around the world and has 63 members, from private sector to NGOs to implementing organizations, all looking to strengthen how we implement work in digital health on the ground, supporting countries. I just want to pause for a moment and say digital health is at the heart of WHA 78. There are no fewer than 26 official and unofficial side events on digital health and AI. And those are just the ones that we know about. I found out last night that there was a digital health event happening from 8 p.m. to 10 p.m. that unfortunately I just couldn't fit in. But for those of you who are excited about the space and want to contribute to these discussions, there's more than ample opportunity happening. I think in the last 5 years, we've seen really significant progress. And our collective work, your collective work, in contributing to strengthening the evidence of what works, in seeing what doesn't work and trying to figure out why it doesn't work so that we don't repeat, really have contributed to advancing digital transformation. And I think that is the moving out of a state of digital in countries, undertake a cohesive journey of digital transformation based on standards, policy, architecture, and good governance. I do, however, have some sobering news to share, but also this news should inspire us to do better. And that is that in the last 3 months, WHO has had the responsibility of hearing from our member states, at least 41 of them, where data continuity and essential digital health systems have virtually collapsed or catastrophically stopped functioning because of a sudden decrease in overseas assistance. 41 countries. And this means that we are seeing systems that supported clinicians, systems that supported frontline health workers, systems that ensured that HIV patients got the drugs that they needed on time to ensure positive, sustained health outcomes. So I think these critical service and data continuity failures should be for us a wake-up call. Because over the last 10 years, many of you have been part of declarations, commitments to principles for digital development, principles for digital investment. Had we adhered to those principles, I regret to say we would not be in this state that we are in today. So this is a wake-up call for us to improve those best practices, to recommit to those principles, and to call out where we see those principles not being applied, where we see local production not being at the heart of interventions, where we see local capacity and local technology not being strengthened as a pillar of resilience to external shocks. So let's focus on making sure countries have architecture, standards, interoperability in place to be resilient no matter what happens externally to these systems that are not just nice to have. In 2025, increasingly, these are becoming the backbone of health systems globally. We've made a lot of progress, and rather than sit here and for me to tell you the progress we've made, you'll hear a lot about it in the coming few days. Allow me to introduce someone who can speak much more authoritatively on the subject. It's my privilege to introduce WHO's Director General, Tedros Ghebreyesus, who has recorded some remarks for us today. Thank you. challenge you to read his lips.
More inclusivity, more effectively, and definitely when this time when demand response, they for people. Workers are paid on time. People carry their health records with them and access care across borders. And governments can track health spending and make sure it reaches the right place at the right time and has the expected result. These are not future aspirations. Their outcomes we're already seeing in many countries, but they require more than innovation. They require alignment between partners, policies, and priorities. They require strong foundations in governance, infrastructure, financing, and trust. And they require countries to lead their digital health transformation based on national strategies and local systems. That's why the extension and renewal of the global strategy on digital health is so important. It contains actions countries have prioritized for WHO, for partners, and for their own digital transformation. Since 2020, we have made significant progress together. 129 countries have now developed national digital health strategies, and almost 70 countries have assessed their digital maturity through the Global Digital Health Monitor. More than 1,600 government officials have been trained in digital health and artificial intelligence. Through the Global Digital Health Certification Network, more than 1.8 billion people in 82 countries now have secure, portable access to their health records, helping countries develop national digital health architecture and governance frameworks. The WHO Science Council has also focused its work on the responsible use of digital technologies in global health. We're supporting the responsible use of artificial intelligence with guidance on ethics, safety, and regulation. And through smart guidelines and capacity building on open standards, we're enabling countries to build locally owned, interoperable solutions. WHO's role is to advance science, to set clear and trusted standards, and to help countries build systems that are resilient, inclusive, and sustainable. Because the only digital transformation worth pursuing is one that leaves no one behind. Together, we must ensure that the use of digital tools to narrow inequities rather than widen them, that data is collected and used ethically and transparently, and that every tool moves us closer to a world where health is not a luxury for some, but a right for all. I thank you.
I hope you are excited for our program today. My name is Mirana Rondrien-Belunoro. I'm working at the Geneva Digital Health Hub.
Hello, yes, and I'm Alexis Baudin, working also at Geneva Digital Health Hub, and we are really happy with Mirana to open this day with all of you with the first session, Exemplar in Global Digital Health. And so welcome to this very rich day.
Before starting the session, we would like to share some logistical information with you. So we really have a rich program with 4 tracks. At the end, we will have a fail festival and then a reception with the very delicious food. We will have, of course, break in betweens. There are also numerous volunteers who are helping us today, so they are recognizable with the yellow badges. So if you have any question, don't hesitate to reach out to them. Thank you as well for our online participants who are following us. We had almost 1,000 participants who are joining us online today. So thank you for following us.
And so, without waiting more, let's begin with this first session in Exemplar Global Digital Health. So during this session, we will highlight digital health programs that have successfully scaled at a national level. And so the speaker will present their key lessons on implementation, sustainability, impact. So
without further ado, it's a pleasure for me to introduce Professor Shmisha Argawal and her panel on drivers of digital transformation for primary healthcare. Shmisha is the director and associate professor at the Center for Global Digital Health Innovation at Johns Hopkins Bloomberg School of Public Health. Shmisha, the floor is yours. Let's welcome her with a round of applause.
Hi, everyone. It's great to be here today, and I'm joined here by my colleagues, Meredith Kimball, who directs health systems at Gates Ventures, and Molly Bode, who leads this portfolio of work at McKinsey Health Institute. And Meredith will actually get us started. So Meredith, please welcome on stage.
Great. I think there are slides that are not appearing, but I'm going to take a minute to just give you a little bit of an overview of the Exemplars in Global Health program. At its core, Exemplars in Global Health is based on a simple idea that one of the best ways to accelerate progress is really to look at peer countries, to learn from other countries who have gone through similar challenges and have found strategies that work to drive progress. Ultimately, the way we think about our North Star for the program is whether or not we can use the lessons, the insights that come from these deep country experiences, from the research that surfaces those insights to inform real-time decision-making. When we think about decisions, we're talking about funding decisions, strategies, policies, operations. And so that's very much what drives a lot of the work in terms of how we think about what topics to take on, how we shape some of the research questions that we prioritize, and then how we think about partnerships for driving uptake. Would certainly invite everyone in the room, if you hear something today that sparks ideas for you, you think there's a way to use this in work that you're doing, let's talk. We'd love to support that. And I think that's very much why we seek to exist. The program started about 7 years ago. This slide is dense. I would invite you to look at the website and learn a little bit more. But what it represents is the breadth of work that exists across the Exemplars in Global Health portfolio. We started with just a couple of topics at the beginning. And I think we've now expanded to over 15 plus topics, looking at, I think, more than 35 geographies. So all of our topics, again, it's demand driven based on interest that we're hearing from countries, from partners, where we think there's something that we can bring value to in this space, insight to surface, and an opportunity to drive uptake. So I also want to highlight what we call our logo soup slide. This is just a representation, but what it's meant to convey is that Exemplars is really a broad network of partners at this point. For every topic that we study, there's a consortium of research partners. We're joined by many in the room today. We also have close partnership with governments who are working with us to shape this, and other partners who help ensure uptake. So we have a small core team from Exemplars that's based at Gates Ventures, and we'll be moving into the Gates Foundation in about a month. But this is a really broad network, and Exemplars, I think, is made possible by all of the partners who work with us. So shifting a little bit into the work on digital health, I think some context here. We had done earlier work looking at primary healthcare systems within Exemplars, understanding drivers of progress retrospectively. Data shows up in those stories, but it's really in the transition coming out of the last 2 decades and looking forward that we are recognizing primary healthcare is looking different, right? It's becoming more digitized. And I think the opportunity exists for us to understand better how can digital serve those health system goals. So the work is very much anchored in understanding what are those goals that we're seeking to drive progress on, whether it's access or quality, efficiency. How can digital support that? We debated at the time, should we take this on? Are there exemplars? Is this space mature enough? And I'm so glad that we decided to do it, because I think there's so much learning happening real time. And I think a lot of opportunity for us to be surfacing that insight and contributing to the discussion. So you'll see on the right-hand side of this slide, there are 3 work streams in terms of how we've shaped the work. For anyone who's familiar with exemplars, we have a typical model of looking retrospectively at countries, often looking across a range of maturity. Smisha is going to talk through that in just a moment. We've also complemented that core approach with some additional work that's really intended to get deeper into some of those nitty-gritty operational factors. What are the design choices? How do we think about considerations? Molly is going to tell you a little bit about some of that work that the MHI partners are driving. We're also working really closely with the Joint Learning Network, a network of policymakers who are grappling with these very same choices today. So that's just a little bit of background. I'm going to pause there and invite Smisha to tell you more about the study.
Great, thank you. So I can tell you a little bit more about the study, but first I'd really like to thank the Geneva Digital Health Hub and the opportunity to host this session with them. They've been our solid partners across the Atlantic, and we've really enjoyed having actually largely women-led digital health teams in 2 different continents. So it's been really fantastic collaboration. So moving on to digital health exemplars, the perspective that we've taken here, as Meredith was mentioning, is really thinking about what do countries need to scale effective digital health systems. And so later today, we'll talk about a number of digital health programs, but the lens that we started with is the ecosystem within which these programs thrive. And so what you see here is how we classified countries based on the maturity of their digital health ecosystem and their current health expenditure. What is the spend per growth in digital health maturity? And these are, I believe, 178 countries, and we identified countries at different levels of maturity with the intention of, or the framework that really came through the Joint Learning Network as well, is what can countries that are at similar levels of maturity learn from each other? And so a country that might be at the level of maturity of Rwanda or on the upper end of the spectrum of Finland. And in doing that, what we've done is also picked countries with a range of healthcare ecosystems, governance structures, and so on, fully recognizing that for a digital health ecosystem to thrive, it needs to be responsive to a country's healthcare system. And here's diving straight into some of our results is how we think about it and how we think about countries based on the observation of all of the countries, what we've identified as key results. So initially, we see that there is a lot of innovation and experimentation. I think historically, we've spoken about it as fragmentation, as pilotitis, but we recognize that that's actually critical for countries to try and see if the ecosystem is ready for digital health interventions to thrive. It also helps create the necessary advocacy to mobilize resources, because some of the upfront investments in infrastructure, in interoperability tends to be quite expensive. And we also see that countries have foundational data building blocks. They may be paper-based or digital building blocks. We can think of those as digital identity, maybe payment systems, just simple paper-based birth registries and other key pieces that allow us to track patients longitudinally. On the far end of this figure, you see the direct patient access and engagement. And that's really the North Star, right? Like when we're saying, let's digitize our primary healthcare ecosystems, what we really want is for the patient to be at the center, or the client to be at the center and empowered with the knowledge of their health data and their health records, for them to be able to go from facility to facility, choose providers, and to know how to manage their healthcare journey. But to get to that North Star, each of these building blocks are critical. So the next level is aggregate data analytics and visibility. And we see that with the district health information systems, which we see in multiple countries, often using DHIS2, where aggregate data at the district level is made possible by the availability of some technological capacity at district or municipality or state levels. Before we move on to interoperability and individual level health records and availability of, I guess, electronic medical records, for example. So this is sort of an overarching view, but we also move on to some specific programs within countries. We were really hoping that there'd be an opportunity to have several of these countries represented on the panel today, and for various reasons that wasn't possible. But we looked at these programs across Rwanda, Ghana, India, Brazil, and Finland, and I'm going to talk through these very quickly with how we've approached understanding the ecosystem within which these programs thrived, as well as how well these programs at scale are working. So here's taking a look at EpiTracker in Rwanda, which has scaled nationally. EpiTracker allows longitudinal tracking of immunization records for children. And what we see is that when the system was digitized, there was a decrease in children dropping out, the dropout of vaccination systems. We also see significant efficiency gains, 10 hours of time saved per facility in reporting, in vaccine stock management, over 22 hours saved per facility per month, time saved for registering children and for identifying defaulter lists. So really solid, measurable efficiency gains. I want to also point out that, we've been doing these types of evaluations for nearly 2 decades at this point. And in the early days of how we approach this, we were always asked to some extent, often by donors, to look at lives saved. And I think there, at least personally as a center for myself, I've thought about how do we reposition that, because often digitization is resulting in process efficiency. It's resulting in operational efficiency. We can't, at least from a measurement standpoint, link that to lives saved. But we do see this value, right, in children dropping out of vaccination programs, for example. Another example from Ghana with Claim It, which is the digital national health insurance claim system. And what we see is, compared to manual claims, when the system was digitized, there was a significant decrease in submission time for the claims and in getting payments back. So again, from a healthcare facility perspective that's looking to get reimbursed and having timely cash flow, that's really critical. And I guess one thing to point out here in terms of the enablers of success for Ghana is that this was really made possible by a thriving national health insurance system in the country. And so really digital was a way to get a means to the end of optimizing an already relatively well-functioning national health insurance system. Moving on to Kuchi Baby in India, which was really in the state of Rajasthan. And they've had a very data-driven approach. And by monitoring population level health parameters, they've been able to link health and environmental metrics together to understand some of the climate-related changes on healthcare. Early on in their programming, they've also been able to impact about a significant improvement in immunization rates. But for India, I really wanted to talk first about what is enabling a lot of the digital transformation. It's impossible to talk about India without mentioning the new, not so new, Ayushman Bharat Digital Health Mission. But what enabled this national digital health policy to really get off the shelf is this history of experimentation. And so really reframing, I think, some of the experimentation that happened going back as far as we went back to 2007 with the first introduction of a smart card, the idea of health on a card, moving on to when the first scale digital public health infrastructure was created with a unique digital ID. And so thinking back to my first figure of how I was describing most countries' journey towards digitization and the key building blocks that feed into this digital ecosystem. There was also a shift from cash-based to a digital payment system. And then in India, we introduced a new insurance scheme, a national health insurance scheme with PMJY. There were a number of other policies that shaped the digitization, but what really took the policy off the shelf, so to speak, is COVID-19 and the push towards telemedicine and optimizing the policy and legislation landscape for digital health. So talking now about Brazil, which is really quite a leader in digitizing primary healthcare ecosystem. And what has really supported the transformation is how Brazil has thought about financing digitization through its primary healthcare, where rural and remote communities, the poorer municipalities, have been financed, not for submission of data, which tends to be the more typical policy, but for ensuring that the key infrastructure and personnel exist at the primary healthcare facility level that can absorb any changes from paper-based to digital systems. So the graph you see here on the left shows sort of the rapid rise since 2018 in in electronic health records. And what you see on the right is some work that our students did where they went through every health encounter bit by bit in the EHR system and saw the transition for how health encounters in sexual and reproductive health were recorded in a paper-based system. And so that's the flat figure on the left. And then after it was digitized, simply by having a drop-down menu, the healthcare providers started coding their data with a lot more granularity. And so instead of getting data at, patients coming in for a SRH encounter, we're able to get sort of the specific type of encounter they're coming in for. And finally, moving on to Finland, I realize I've thrown a lot of information here at you, is they've moved to the far end of that initial framework where they've really, because there's been adoption of the electronic health record, now they're able to focus on how do we ensure that citizens have access to their health information through the My Kanta pages, where citizens are able to schedule appointments, keep up with their health records, and follow up on necessary post-encounter follow-ups. And a lot of it, is made possible by the leadership and governance structure in Finland, which we can talk at length about. I might skip over this slide to give Molly some time, but I wanted to invite folks we are having a series of dissemination opportunities that go into much more detail of this work. The second of these is coming up in about 2 weeks on how is the digital health ecosystem engaging with the private sector for digital transformation across several countries. And if you want to keep up with what else is coming up in terms of dissemination, the barcode can help with that. So thank you very much. And I will transition to Molly Bode.
Hello, and hope folks are still awake and alive and all of that. Thank you, Smisha, for the amazing tour of multiple countries, and thank you, Meredith, for opening us up. Also, thank you to Geneva Digital Health Day for such a wonderful organization of events today. I'm Molly Bodie. I'm a partner at McKinsey & Company, and I'm also a leader of McKinsey Health Institute, which is our nonprofit entity, which is trying to both catalyze and extend quality years of life. My colleague Marilyn was supposed to be here, but she had some travel snafus, so she's here with us in spirit. So as Meredith mentioned at the very beginning, we actually are, as part of the Digital Health Exemplars Consortium, are doing what we're calling thematic deep dives. So we're actually deep diving into different topics. And so through this effort, we've actually been able to deep dive into 2 different topics. One, interoperability. The second, private sector engagement, in which the research is still ongoing. And the reason why we chose these topics is when we actually talked to countries through the Joint Learning Network, which is run by the World Bank and part of the consortium, as well as many other stakeholders, these were 2 top priority topics. And so what we've done is we've actually gone through a very very sort of strategic process to say, what are the questions that countries are asking? Which countries may actually be of interest to study? How do we actually learn from what's out there in the literature? How do we learn from experts in the field? Then what are we actually synthesizing in terms of the option set, the design choices that countries have made? And then working, of course, on dissemination through the partnership as a whole. Through this effort, we've looked at actually a different set of countries, so 5 different countries than the ones that the Hopkins team has been looking at. But we looked at Canada, Estonia, Mexico, Togo, and Tanzania, which represent really quite different systems and environments, different levels of maturity, different languages, different governance structures, which have also given us different insights into the ways that countries actually take these pathways towards interoperability or take the pathway to actually engage the private sector. We've also sprinkled in lessons from other countries along the way as well. So going into interoperability, I think probably folks in the room actually really believe that interoperability matters. It can help you get to a place where you can reduce readmissions, increase access by enabling sort of the digital ecosystem as a whole. And so what we looked at was, how did actually countries make decisions to get to an interoperable system along the way? And so we looked at 7 key design decisions. In strategic approach, which is sort of the top of that house that you see, we looked at sort of what's the governance and operating model. We looked at what's the timing and phasing for how countries actually approached this. What's the financing mechanisms? Did they do it on their own? What was the financing way that they did this? And then really getting into a bit more of the architecture and technical design, and then saying, okay, how did that all come together? What ID mechanism did they use? Or what ways were they actually making this interoperable? And then lastly, we looked at actually user engagement. So the adoption, how did they actually drive adoption of tools which would connect into the interoperability layer, and actually what's that capacity building that they did? What we found when we actually looked across these 3 countries is that while interoperability requires standardization, actually getting to interoperable systems is not a one-size-fits-all model. And so context actually really changes the way that countries engage and actually take a pathway towards interoperability. And so just examples of this is that in Canada, the governance and operating structure, where it's a very decentralized system where provinces and territories actually own and invest in their own interoperability, has actually really changed the way that they've approached their interoperability itself. And in Canada, as an example, they actually have a nonprofit, Health InfoWay, which helps provide more national guidance and standards, but just has changed the way that they've approached this as a whole. Financing also really matters. And so just an example of this is when we looked at Tanzania, which is funded by both government as well as donor partners, it really took a different pathway. So you saw more use case based interoperability occurring within Tanzania. And then lastly, what's that digital infrastructure that exists or not? That also changes the way that the country may take a pathway towards interoperability. And so Estonia really built on their strong digital infrastructure to take this pathway towards interoperability. We actually, in a paper that we released just a few months ago, we went through lessons across each of these areas, and we also have deep dives by country. And so this is a really, really, really high level snippet of the research that's in there, but we really looked at, okay, what's that challenge? What's the lessons learned? Where did we actually see this different options being taken by countries? And so, of course, just mentioned how the governance structure of a country may actually change the contextual choices. So when we see sort of across the research, we found that national structures actually do help streamline that process. We also saw, as discussed earlier, that financing really changes this as well. And so how do you approach financing? Well, it has a very different option set from where you're coming from. We also looked at, lessons around low adoption by providers and what could you actually do to incentivize adoption of tools that connect into your interoperability layer. An example of this is in Estonia. the government actually provides subsidies for providers to actually use and integrate themselves, which is used in many countries, just an example of that. And then also some lessons on capacity building. So you can actually go into the paper and find out more of these, but this is just a teaser and a snippet as well. What's also interesting is that when we actually looked at interoperability, you know, even for those that are high digital maturity, so for Estonia, which was 5 out of 5, I think, on the index, you should correct me, Smisha. But also for those that actually have high digital maturity, and that for those that actually have a strong national plan, and even had the sort of the vision to get to more interoperability systems, it takes time. And so when you look at the example case from Estonia, they actually in 2008 launched their health information system, but it took 5+ years to get to significant traction of actually queries into that system, and that usage really didn't rise for a number of years. And so it really takes time. I think everyone in this room knows that, but Estonia, which is a bit more of an advanced system, just shows that as well. The second topic that we looked at was private sector engagement. And so when we think about digital health, we recognize that in order to get to a digitally enabled ecosystem to help support better healthcare overall, you often can't leave out the private sector. And so we looked at actually private sector mostly from a software or hardware perspective. But we actually looked at private sector and sort of why do you engage private sector actors? Who do you engage? What do you engage? And how do you engage them on that? And when we looked across 5 different countries, again, a range of different countries here, from Canada to Estonia to Mexico, Togo, and Tanzania, we actually found that there's many reasons why you might engage the private sector. So it might be from a capability standpoint, from financing, or the ability to scale. And we saw that actually most countries were engaging the private sector for multiple reasons at once. We also found that there's a wide range of the types of solutions that countries are also engaging the private sector in, whether it's for EHRs, whether it's for e-prescription, whether it's for telehealth or something else. So this research is actually still ongoing. We will be working to publish and disseminate this soon, and also it'll be at the webinar upcoming, which is really exciting. But to give you a bit of a teaser, what we've seen in terms of lessons, which are still emerging, is that effective private sector engagement really actually takes concerted effort. And in places where you don't have strong digital maturity, or where you actually have sort of a flourishing of many, many different pilots or entities partnering with trusted actors, even if they're not necessarily of the technical kind, can actually help you improve that solution quality. So that could be with established foundations, that could be with others that actually help you create transparent procurement processes or transparent engagement ways as well. We also found that incentives that actually help foster local ecosystems can actually help create a more vibrant and health equitable private sector engagement ecosystem. And so we looked at a couple innovation hubs, which we'll highlight later on as well, which actually can help boost the overall ecosystem. We also saw that sort of establishing, I think Dr. Lebrique and others, we talked about this, I think yesterday, but actually having a strong digital roadmap will actually help you align those private sector stakeholders to what that national goal is. So it's not just solutions out there working on problems which may not be fully aligned with the context or the national goals there. Of course, data privacy is one that is raised all the time when you think about private sector engagement. So found it's really critically important, of course, to be aligning with, of course, the regulation within country, but also being really transparent about how you're doing that. And then lastly, the sustainability of digital health systems, and particularly in the private sector, is really quite critical to get right. And so what we saw is that actually some of the phased ownership of how are you building it to start, is the private sector fully owning it? Are you passing it off? And how are you doing that sort of phased ownership transition matters. and that sometimes interesting financing mechanisms such as deferred financing or even equity stakes can actually help with the sort of longer term road to financing sustainability. So that is it. That's a teaser on the two, and I'll hand it back to Meredith.
Thanks, Molly. This slide, I think, just gives you a snapshot and is meant to say there's more, I think, underneath everything that you heard. There's work still in progress. So the webinar series is ongoing. I hope you'll tune in. Again, the Joint Learning Network, I think there are 15 or so countries that are also kind of co-producing knowledge products on these topics. Those will be forthcoming, I think, over the remainder of this year. And so just invite you to connect with us and continue to follow the work and learn more. I might look at the organizers. I think we have a few minutes perhaps to take questions if that's a possibility. We will not take questions. Just kidding. Come talk to us during a break. Then I think maybe we'll pause there and hand back to the organizers. And thank you again for inviting us to be here today. It's a pleasure to join you in this conversation and look forward to more.
Thank you, Smisha, Molly, Meredith, for this panel that was really insightful, and thank you for giving us and respecting the time and giving us some minutes to have the time to fill the program. So now let's welcome Sithuraman Venkatram, who is president of HealthTech Argusoft India Limited, for his solution pitch MedPlat, how to scale a comprehensive primary healthcare solution to 300 million citizens. Let's welcome him.
Which is the slide? Move the slide is okay. Hey, namaste. Good morning, Geneva, and to everyone. The slides aren't moving. I'm sorry. Can you go to the first slide, please? On the first notes, the first page note. No, the previous one. Do you want the previous one? Previous one, the first one. No, you're going to the last ones. The very first one. Shall I use my laptop? No. This is not the presentation. No, this is not the presentation. This is the next one. I'll use my laptop. Is it okay? Yeah. Sorry. Yeah, this is the one. Thank you. Good morning. Sethuraman from Argsoft. So today we are going to talk about a platform called MedPlat. This is being used in India and in some countries in Zambia and Cambodia. And this is a platform which has scaled. And we'll talk about this. What are the common challenges that are there in this space, the community comprehensive primary healthcare space? So if you look at it, geographies vary. There are systems which are different in terms of its maturity, the workforce roles, and then the priority. So they need a platform that adapts to their situation. We heard about it. People were talking about it just now. And then there is also the disparate. Right now, what is happening is there are very different systems for different programs in each of these countries, each of these geographies. And they often operate in multiple disconnected ways. Yeah, so they happen in multiple disconnected silos kind of a thing. So which is essentially the workforce is having to re-enter the data in multiple systems a lot of times. It's sometimes paper-based, it's sometimes digital systems, but then they are having to enter it in multiple different systems. So this is actually taking the time away from what they are supposed to be doing, which is actually talking to the people, providing them the healthcare that they need. So that is not happening. And also what is happening is that, when these systems, there are new things which have to be added, then there is a problem there. People have to go back to the coding to actually make those changes. And it takes a lot of time. Even if you have to add something very simple, it takes a lot of time for them to come to the developer, get it done. And then again, moving it to all those various people out there, that's a big challenge. And we see this in multiple countries on regular basis, multiple implementations have this challenge. So this is one important thing that we are trying to see as a challenge which has to be addressed. And then we talked about interoperability. Just now we saw wonderful speakers here talking about how interoperability is different for different contexts. And the seamless interoperability, right now interoperability happens, but it's more for data and reporting is what we see. However, what is important is probably how can the data inform precision medicine? How can a longitudinal health record be available to the patient themselves and to the providers when they need it? So that seamless interoperability seems to be a major challenge in most of the health systems that are present today. Now, how do we address these challenges? What are we learning and what are we trying to do with MedPlat? One, we understand that different geographies have different needs. So we can't be building for each geography. So the platform has to be configurable. So we are trying to make it very configurable. For example, in Uttar Pradesh, there's a program called eKavach that is based on MedPlat. There was a Japanese encephalitis work that had to be done. It was configured in 3 weeks. In Zambia, we worked with PATH. There is a system called CHIP that is running there, which is scaling up very well. And there, the entire multi-program configuration happened in less than 4 months. So these are things which are possible when you have a system which is designed to be configurable, rather than trying to go touch the code each time and make the whole program work all the way right from the beginning. So configurability is something which we have seen, which we have learned, is something which is very, very useful. Second thing is, when we are talking about interoperability, how can it be standards based? We know that we have the ICD standard, the SNOMED standards, but some of these systems are looking at it probably at a superficial level. So the system has to be interoperable. It has to follow the standards. And more important, when we are talking about interoperability, FHIR is the way to go. And we are doing that in MedPlat with FHIR interoperability. We are now able to exchange data between systems with any system. You don't have to really understand the system. It's a point-to-point or it's a bus. You will still be able to exchange data because it's all FHIR. All systems which can read FHIR will be able to read the data. And this also evolves rapidly with the system in the country. The country decides what they want. They know best. They have their needs. They have their priorities. The system should adopt to the environment and not the other way around. So MedPlat configuration workflow, say for example, a government says, okay, there is a protocol change or there is a new evidence. Maybe we have to HPV vaccination or the postnatal care protocol has to change. All somebody has to do is use a browser kind of an interface and go there and do whatever changes that have to be done. And it can immediately be sent to all the health workers on the field instead of having to have a separate drop sent out and all those other things which many of us in many implementations would have faced. And of course, this is open source. And the open source, it's not just about code. Somebody was talking about, and even the DG was talking about it. It's not about the technology. It's about the environment, right? And here the community is involved. The community in terms of both the user community as well as the community which is developing it. So while you put it out and make it open source, then people go look at it. They want to contribute. They can also download, use it for their purposes and keep suggesting more things to be improved. So that's the advantage of open source and making it a DBG. And why this matters most? One, the question we have to ask is how can health systems implement changes effectively, faster? This is one question we have to ask for any system. And the answer is the way it can be configured. How can programs be configured? And that's important. The second question we have to ask is, are we ensuring that the frontline workers have more time for patient care? Which means the interface has to be simple, and that's easy said than done. And we have seen this in multiple cases. And it has to be very, configurable again, so that if they have a problem, they want to change the language, they should be able to do it right away. And then with today's technology, whatever investment, are we investing in the technology or are we investing in the ecosystem? That's a question. It's not about what program, whether it is MedPlat or something else. It's about the actual, the investments. Are they staying relevant for a long period of time? I have RMNCH today. Can I add NC2 to it very quickly? And the data that we are collecting, is it being used for local action? That's the important thing. The data that is being used today is more for the dashboards, which is important, which is useful, which is for policy. But does it just do that? Or can the health worker have data for local action? And we believe that the scalability, configurability are technical, yes, but they are not just technical features. It's more about the ecosystem play. We have to see how the ecosystem can adopt it. It's just a small part. And the tail cannot wag the dog. And we have to make sure the technology understands that very well and work with the ecosystem to make it work. The real question, of course, is, are we investing in technology or are we building solutions that scale, adapt, and stay relevant? Would invite you to scan this QR code, engage in conversations. We'll be able to answer as many questions as we can. And this is a team. This is an approach that we have to do all together. Thank you for the opportunity. And sorry about that initial slide stuff. Thank you.
Thank you so much, Setu Raman. Now it's a pleasure for me to invite to the stage Émilie Porello. Émilie Porello for her solution pitch on successfully scaling integrated health system in the Pacific, national level implementation and impact of Tupaya and Tamanu. Émilie Porello is head of programs of Beyond Essential Systems. Émilie, the floor is yours.
Merci. Bonjour. Okay, Tamanu is a free and open source electronic health record for low resource settings. It's a digital square global good for health, and it's implemented in 6 Pacific Island countries, including being the national system in 3 of those. Now, the Pacific Islands, they are some of the most beautiful settings in the world, but they're also some of the most challenging to deliver good healthcare and to implement and sustain digital health solutions. Tamanu was really designed to help overcome those challenges. So the first one is obvious: infrastructure. There's poor internet connectivity, particularly at remote primary care health facilities, but also often at the referral hospitals in the capital cities as well. So systems that are web-based are often not suitable for this context. Tamanu is sync enabled. That means it works offline whenever the internet is down, and it will automatically synchronize data to and from the central server whenever internet becomes available, even if that's only just for a few minutes. The second challenge is financing. So these are very low resource settings. So expensive ongoing licensing fees associated with commercial systems are often not sustainable long term, even if a development partner is supporting the initial implementation. Tamanu is free and open source, so there's no mandatory ongoing licensing fees. There are optional support and maintenance fees that countries can opt to be a part of, but if they don't pay those fees or they choose not to be part of it, the system is never cut off. And importantly, that can never change due to the licensing model. So there's a real shift in power dynamics from the solution provider to the country. Health systems in the Pacific are very geographically dispersed and isolated, creating huge challenges for continuity of care. Tamanu is desktop and mobile enabled, so that means you can use the same system all the way from community to primary, secondary and tertiary care. So the mobile system can be used for things like a community outreach program for immunisations or NCD screenings, while the desktop version can be used in more complex settings such as hospitals. So it's really supporting this development of a birth to death record, supporting continuity of care for patients. Health systems in the Pacific and many other low resource settings are really saturated with fragmented digital health solutions that don't speak to one another. This is really challenging for health workers in the Pacific who tend to wear many different hats. So it's the same nurse that's doing NCD screenings one day, an immunisation program the next. So the idea that this health worker is expected to pick out a different app for each different clinical condition or public health program that they're managing is really not sustainable in the context. So Tamanu provides a single app for all clinical and public health encounters, really helping to reduce the burden on the health worker. It also has an HL7 FHIR compliant API, meaning that it can integrate with other core digital health systems like your lab system, supply chain system, DHIS2, or Tipaya, which is our app for data aggregation, analysis and visualization to support data for decision making. And finally, it has a really nice, modern, clean interface, making it easy and intuitive to use for health workers, particularly important for a workforce often with limited digital literacy. And it goes without saying, there's comprehensive security with data encryption to protect the highly sensitive health data being captured. So I'm going to conclude with the keys to success in scaling Tamanu at a national level in the complex Pacific Islands. I've spent a lot of time talking about the principles behind Tamanu, and that's because they are a must, not a nice to have in the context of the Pacific Islands, and I would argue also for other low resource settings who face similar challenges. But of course, the software is just one part. You also need an implementing partner that deeply understands the context. We do this in several ways, one of which is first and foremost by employing Pacific Islanders on our projects and working with Ministries of Health to transition those roles into permanent Ministry of Health positions later. We would really love to explore partnering with other organisations that deeply understand other contexts, such as those in Southeast Asia, Africa or Latin America, to see how Tamanu might be appropriate for those settings. And finally, many Pacific Island countries and many other low resource settings are still putting together the building blocks for digital health. But if you wait for all of the building blocks to be perfect before you start implementing core systems like a national electronic health record, you will wait forever. So in our experience, we've really sort of flipped to this paradigm and have been introducing Tamanu alongside the building blocks. And what we've found is that once you introduce a system that delivers real benefits, tangible benefits for clinicians and health workers, this helps build momentum and enthusiasm for the building blocks, which are critical, but often more difficult to garner support for. Merci beaucoup. Thank you, and come and have a chat later.
Thank you so much, Emily. Thank you. So now we will introduce the next panel. So let's welcome Tessa Lenman for her panel, Collaborating for Impact, Strategic Alliance for ICT Competency in Health.
Hello, everybody. Welcome, and thank you for your attention. I'm inviting my panelists from all over the room. I think come join me, Jai, please. And Jennifer and Derek, come and sit with me, because otherwise I will feel very, very lonely. All right, thank you very much. So yeah, my name is Tessa Lennemann. I have the honor of moderating this panel today. And we wanted to talk about capacity building in health, recognizing that while digital health is really giving us a lot of opportunities to save resources in developing countries. For example, in Africa, we're expecting that we could save up to 11 billion in healthcare funds if we would actually roll out digital systems. In Asia, I couldn't find respective numbers, but it's understood that the healthcare market will grow by 23% per year. So there's like a lot of demand on the market, and we have to recognize that human resources is the scars, the bottleneck, which most probably will hamper nationwide implementation. And human resource is, or digital capacity in human resource is relevant for the healthcare sector, and it is relevant for the IT, the tech sector, right? Because you want to have people who can grow the solutions, who can, build them locally, as we heard in the morning, who can adapt, bring in new models. So it is really important. Human resource is really important across the spectrum. And I know that many of you are engaged in working developing capacity, but maybe we all have worked, building different pieces, knitting our little, square. And the question is now, how can we stitch all these activities together, and what should we do to actually, do our best, bring all the resources together and join forces to grow, ICT capacity in health. So with me here, really, I feel key people that have really inspired me in throughout my journey, and I'm just inviting them to, for one, introduce themselves to you as the audience and outline a little bit what so far they have done to build capacity in IT, so that we in healthcare, so that we can build up on that and see where we want to go together from there. So please, I think Jennifer, you can start.
Good morning, everyone. Thank you for this opportunity to share with you. So I have been working in digital health for over 30 years. Some of the things that I've worked on include Open HIE, which is about building capacity for health information exchange. But what I want to focus on today is I've had the privilege of partnering with GIZ, PAHO, UNICEF, and others on a DIPC project where we were focused on doing some qualitative research to understand capacity strengthening needs, especially of HIS professionals in the field, understand their needs, understand the barriers to capacity strengthening. And within that project, I got to work with partners to develop some key materials that can be shared. But I think one of the things that we learned as a part of that project and as a part of just different work in global health is that if we try to take the end user perspective about capacity strengthening, what we realize is that we haven't made it very friendly for a person to understand what's available for them to build their own capacity. In other words, you have to know who to talk to and where to go to get materials. We've also not made it very friendly for the individual who's responsible for building capacity within their country or their organization. And so I'm really excited about the opportunity. As Tessa mentioned, we've each built a little square maybe of a larger quilt. And if we could work together, I think it would be much easier for individuals to harness the great materials and resources that are out there and be able to move forward faster together. And so I'm really excited about that opportunity. And I'm going to hand it to Jai, who's going to talk next.
Thanks, Jennifer. This is Jai. I would like to actually share from the point of view of a regional digital health network. And AHIN has been like over a decade now, has been focused on like capacity building and training, has been one of the core areas of focus. And then since we actually work, our mandate is to work closely with the ministries of health in the region, the priorities and the choice of training or capacity building is actually linked to what exactly is needed on the ground. So we try to actually often mix and match, and then a lot of trainings, both in-house prepared or certifications that are available elsewhere, like we have facilitated them. So I would like to actually share from our perspective of like what has worked and what could actually be still be done in an alliance like Stitch, which Tessa mentioned, how we can all bring it together, especially in the trying times currently. Maybe I would stop it at that and then come with the next round of explaining what exactly. Over to Derek.
Thank you so much. That was a very nice abrupt ending. It was just getting to the climax. Thank you so much, Jai. looking forward to the next round. I just wanted to thank Tessa, and Tessa mentioned that the panel inspired her, but I'd like to take that in reverse, that we've been inspired by the kind of momentum that Tessa and the organization have provided. My name is Derek Mnene. I am Capacity Building and Partnerships Head at the WHO, and our mandate is really to support the digital health ecosystem in the journey that they are undertaking, and Stitch is one of the areas that we'll be looking at very closely. Our member states, as you could have heard this morning, discussing the extension of the global strategy on digital health. And we've been quite excited by the contribution of all of you in terms of the member states' transformation agenda. Member states have given us 3 resolutions from 2005, 2013, 2018. Inside those resolutions are elements on capacity building and really focusing on the health workforce and the ability to actually engage digitally. The African region actually in 2010 specifically called for the capacitation of the health workers to really move the agenda of that 2010 resolution on e-health. We all recognize that to transform a sector is really 3 things. It's people, it's a technology, and the processes associated with ingesting that particular technology. And so we're quite thankful that this attention is being given, this area of capacity building is being given attention. From our last survey on e-health in 2015, we did see that countries were progressing in other dimensions of the digital health ecosystem. Health workforce capacity building is one of those items that were lagging behind. And the data that we see in the Global Digital Health Monitor also attests to the fact that countries are succeeding in as far as implementing, interoperability standards and as far as putting together legislation, but it's really the human factor that is really lagging behind. So at WHO, working with our partners, where we are focusing on really ensuring that we leave no one behind in as far as digital health skills is concerned. We're working on a global digital health competency framework that will articulate the knowledge, skills, and attitudes of policymakers, planners, and practitioners, and eventually, the citizens themselves. And so through Stitch, would like to sort of like lay this foundation so that the Stitch approach can actually see the light of day. Thank you so much, Tess, and back to you.
Okay, thank you very much. Yeah, so I think you have seen there's a lot also already happening, but there's a lack of, maybe there's like a little bit of coordination missing. So my question is, we are all talking about Stitch and stitching things together, and I want you to take this verb with you. So what is it that the added value could actually bring if we join synergies? Because in the end, you want to do this for, an improved outcome and not just because it sounds very nice. So I don't know.
Okay, I guess I'll go first. I think I mentioned the end user perspective, and I think it's really important that we think about that as we try to move forward. And one of the values that I think we could bring is making the information and the training that probably many of you in the audience, as well as those of us up here this morning, many of us have invested in creating materials and or ways forward. But I think being able to have that in a platform or a menu or a central place where it's accessible. So I think about one word as accessible, making things accessible so that individuals and or people in countries and or implementing organizations have the ability to access it and build from there. I think the other word that comes to my mind is I'm going to use configurable, or the ability to modify the materials to suit the context. I think that's important. And so those are 2 things that come to my mind as values that we could bring as we work together, is to make it accessible and also configurable to fit the context.
Thanks, Jennifer. I would like to add on to what Jennifer said. I think to have the content of training contextualized locally is also very important, because some countries that we work with, though we have facilitated multiple trainings but most of them are in English, but there are countries where it is difficult to have for them. So we are also working through what we call is the AHINS Working Council, where we have official nominations from 15 countries in the region, and then 2 more are likely to join very soon. Through them, we are also trying to actually translate it into the local content because that's also important. And most of the courses like that also focuses on, say, digital health leadership and things like that. They have certain use cases that may or may not be relevant. I think a regional network like us, like where the value lies is to bring in that kind of a regional experience or use cases that are more relevant in that particular region or country. I think if that is actually weaved in as part of the the capacity building, I think that's more meaningful. In fact, AHIN has a digital health capacity development roadmap, I would say, for years now. And then that focuses on leadership, scalability, interoperability, sustainability, universality, as well as evaluation and strategic reuse. So we had this roadmap, and then we actually mapped it to existing trainings, including certifications. But then, we would like to actually mix and match based on the ground requirements. That's something that I would like to say. And in March, we worked with WHO, where they conducted a series of virtual consultations on the global digital health competency frameworks. We were part of that exercise as well.
Thank you very much. Thanks so much. I just want to compliment that, it was in 2019. I remember when GIZ, thanks to GIZ, by the way, it was in 2019 that we got some resources to do a mapping on who's doing what, where, and how. In terms of digital health training, we did a landscape analysis and really discovered the multiple different courses, as Tessa mentioned, that were unstitched. The fragmentation that we saw was quite evident. And so the idea of a global digital health competency framework, which is our contribution to ensure that competency-based certification actually is realized, that foundational piece is what we are working on with the global community, so as to enable different actors to build on top of that particular framework. We're thankful for the establishment of the WHO Academy that should be leveraged in order to sort of advance this whole idea of competence-based learning. So at WHO, within the global strategy on digital health, we are sort of using that as a foundation to enable this important agenda of ensuring that capacities for digital health are assimilated with everyone across the spectrum. We do have a global initiative on digital health that we're using as a framework, a home to consolidate partnerships around specific thematic area, including this particular area of digital health transformation. Very important subject, and I would really stress that this partnership that is emerging on stage, continues to progress, because we see this as the last frontier in terms of getting a balance across the 7 building blocks of digital health transformation.
Thank you. So as we are talking about talent, about human resources, and about getting together or making synergies, it would also be we appreciate this panel today to actually invite you to discuss with us what a benefit Stitch could be for your setting or for your environment, for the partners you're working with. So I'm inviting now, although if there's someone who would like to comment on this and sort of identify either what kind of courses you actually have already developed, but also what kind of added value could it bring to you and to your work or your partner's work if you would be in some kind of wider initiative or movement like what we are sort of sketching out for Stitch right now. So I'm not sure if there's anyone. Please hold your if you want to comment. Yes, please.
I'll be real quick. One thing that I was saying is, one is the content, another is the delivery. So I was wondering, there are several delivery platforms as well, including something that we are doing. So if there are good content, how can they be adopted and delivered through multiple deliveries? So if there can be a standard of how the content is produced so that it can be consumed by any of the platforms which can then deliver that. So I was just wondering if some work is happening or could be thought of. Thank you.
You want to directly? I think you have another mic.
So I don't think we've been thinking that much about a standard, but more about a way to create an index or a link to content or to make it accessible. So I think there are actually standards for digital training content, But I think what we were just thinking about is being able to have maybe an overarching, I would say, piece of software that could help link users out to the various platforms so that we're not duplicating the content all over the place is kind of the vision that we had. But that vision is very flexible based on what we're able to accomplish together.
Not about the platforms, but what we are trying to do is actually create this training environment in such a way that it is locally sustainable. For example, one of the countries that we are working with, the University of Health Sciences, as well as the technology, so that this training that what we provide is actually absorbed by them and then actually carried on in the local system without being dependent on somebody else coming and doing it. And then we're also trying to create a pool of, we have various communities of practice, whether it is on enterprise architecture or standards interoperability, also digital health blueprint development. So we are forming those communities and getting people, creating a pool of people in the region trained on this so that, they can actually carry on. So they don't need to become dependent on anyone, because that's the only way, because capacity building is continuous and it's a continuous process. It's not going to end. So it's not sustainable unless otherwise, like, somebody picks up in the local ecosystem and carries over. Thank you.
And just in one sentence, I think for our perspective, this is where the competency framework comes in. That sort of like guides what you put on top in terms of what a person is expected to know, to manifest as skills, and also to sort of like advocate for in terms of behaviors.
Hi, I'm Javier Elkin, Head of Digital Health at ICRC, with a question. Thank you so much for these interventions. So training is the beginning of capacity building, but it's not capacity building in of itself, right? So after those trainings, how do you evaluate the actual impact on the system? How do you ensure that something changes in reality after that? And what do you do beyond the trainings to ensure that capacity is maintained over time? Thank you.
I think it's a very interesting and important and pertinent question. We have this, because we have been training this over 12 years now. We found that unless otherwise there are career pathways for them, or after the training, they are actually given an opportunity to put that into practice, it just goes waste. So what we have done in the last at least 3 years is, whenever we seek the nominations from the countries for these various trainings, we actually have a re-entry plan. So after the training, what is that they will do? So we are actually having that in, and then also for example, some of the people who were part of the Digital Health Planning National Systems course, we made sure that AHIN engaged them in our liaison with the country, the ministries of health, and then the projects that we worked. So that's how we actually get them to do something after the training. Thank you.
Last questions, but you're welcome to reach out to us after that. And the ones who are joining online, you're welcome to reach to stitch@giz.de or just write something in the comments. So please.
I'm Medhat Askar from the International Transplantation Society, in official relationship with the WHO. And part of our mission is to support transplant infrastructure in different parts of the world. And one of the things we are working on is developing clinical decision support systems. So we are really looking for any partners to support us, because as you mentioned, there is the content and there is the delivery. So we have the content, but the delivery is something we could benefit from.
Thank you. So I don't know if someone wants to comment very quick. So I think, yeah, thank you so much. I feel there's a lot of input we have to sort of understand and learn to really bring our efforts together. And I think to wrap up this session today, thank you very much for joining us. Please reach out to us if you have content you would like to give to a wider audience, maybe to make it also accessible to other settings. Please reach out to Jennifer and supply it. We have some more information as a flyer, which you can access after this session. And if you would like to be engaged, there is, as I said, this email address you can sort of indicate your interest in. It's stitch@giz.de. And we would be really, really happy to sort of get you all together so that we can work on this together. So thank you very much. Thank you, panelists, for this exciting discussions. And yeah, I wish you a nice rest of the day.
Thank you very much for this wonderful panelists, and thank you for finishing on time. Now I want to welcome Martin Curley. Martin Curley and his solution pitch on establishment and operation of National Digital Health Academy in Ireland to build national scale digital health competency, capability and capacity. Martin is a professor of innovation at Maynooth University, and it's a pleasure to welcome him. The floor is yours.
Well, good morning. Bonjour. How's everybody doing? Good. Okay, I have 15 minutes or 5 minutes to tell you about a success story and how we're going to try and take that globally. And we want to invite you to be with us. So I joined the Irish Health Service in 2018 as the Chief Information Officer. I previously worked with Intel and MasterCard and a few other global companies. I quickly realized actually it was going to be far easier and much more value to work to transform the entire health system rather than transform the IT organization. So I quickly moved on from being CIO to Director of Digital Transformation. I had the privilege of chairing the European Commission high-level group for 7 or 8 years, and myself and a guy, Bror Salmon from the Commission, published this book, Open Innovation 2.0, based on best practice all around the world. It's about how do you transform the industry using digital technology, and we use that. The secret that management consultants don't want you to know is that 90% of strategies fail. But I want to tell you about a strategy that actually worked, because the challenge we had when I joined the HSE, we were 90, 100,000 employees, but Ireland's health system was ranked number 80 in the world. So number 80, so there were lots of companies that were poorer and weren't as established, and we had amazing conditions, but we're number 80. And our chairman, Sir Kieran Devaney, his advice was do one thing and do one thing, do it well. So I took on the challenge. We're going to enact a transformation, and our singular goal is to lift Ireland from number 80 into the top 10. The strategy worked. It was a very non-linear path. It was exponential change, and I can't claim all of the credit for that because many people worked together. But last year, when the CEO World Rankings were announced, Ireland was number 6. So we went from 80 to 6 in 5 years, and that was our 10-year goal. I won't tell anybody in Ireland in that, because if people hear about that, they say, oh, we're done. And we have so much more to do. But we set a vision of a digitally enabled healthcare system. We started a digital academy with colleagues Lorraine Smith and Ross Cullen, and I'm joined today by Aisling Gannon online, who's helping translate the Irish success story into a global success story. So I stayed in the HSE for 5 years, but 2 years ago I moved back to the Maynooth University, the Innovation Value Institute, and we are taking the HSE Digital Academy and proposing to make that an international digital health academy. In 2007, with our current Prime Minister, we established the Innovation Value Institute. It's modeled on the Software Engineering Institute at Carnegie Mellon that drove a structural change in the way companies write software. And our goal at the Innovation Value Institute is to drive a structural change the way governments and organizations get value from IT. A couple of years ago, we were privileged to have Jerome Adams, the 22nd US Surgeon General, as our distinguished speaker. We published something called the IT CMF, which was built by over 100 organizations, and it's the gold standard for measuring and improving enterprise IT capability. We use a methodology called a guided open collaborative ecosystem. If you're interested in learning about this, I published a paper on this in Health Management earlier this year. And it's a way of delivering exponential and multiplicative outputs from an ecosystem of people who are committed to change. Changing a health system is really difficult. And if you do it in a linear fashion, you're completely going to fail. But we took on an exponential approach. We applied some science, we had some luck, and we had some amazing people work with us, and the transformation worked. I want to tell you about one of the initiatives is a vision for a whole new different kind of health system, which is based on people at the center. We call the paradigm stay left, shift left, 10x. Stay left's about keeping people well. or we have a chronic disease or need rehab, we can do that best of all from home. And sorry, my slides are getting ahead of me. Shift left is about getting you home as quickly as possible. And 10x is the notion that we can do things 10 times faster, 10 times cheaper, 10 times better. And we've been able to achieve that in multiple living labs. So I want to tell you about our academy. And education is the first thing you need to do on a transformation journey. And the absolute cornerstone of our success was establishing a master's in digital health transformation. I was able to pull our eight research universities into Maynooth University, all the top professors in the country, and we agreed we would work on developing a world-class master's in digital transformation. We've just completed the 5th year of that master's, and we've trained over 220 clinicians. What was really important, though, we didn't ask these clinicians to write a dissertation. We asked them to drive a digital change project. So we've now had about 110 digital change projects across the system, and they've been foundational. And I'll finish in 1 minute. We've had some distinguished lecture series. We run an international summer school. We just completed that last week, and I've just invited Alan Labrie to be our distinguished speaker. Derek Manine, who was here, he spoke at our UN Digital Health Symposium. And we also run master classes. A very successful one is with Ogun Gurel from the University of Texas, a mini medical doctorate. So I'm going to finish. We are moving this academy from an Irish academy to a global academy. I'd invite you to help us and work with us. There's a QR code here. We're going to launch this academy at our 5th UN Digital Health Symposium in New York on September 21 and 22nd. Maybe some of you will join us. And we've announced an initiative called Mission 10X, initially in Ireland, then globally, to build a 10 times better health system. And we think we can do this with a proactive health mindset, with digital technology and empowering patients. And please, go to the link, fill in our survey, and maybe you'll be part of this academy. Thank you very much. Merci.
Thank you. Thank you, Martin. Thank you for your solution pitch. So the next solution pitch will be presented by Fabienne Coty, who is evidence and outcome research team lead at Ada Health. So welcome, Fabienne. And you will present a solution pitch on empowering maternal health, enabling informed decision-making with IA in low-resource settings. The floor is yours.
Okay, thank you. Let me start with a story. A 39-year-old South African mom was experiencing persistent cough. She at first didn't know what to do about it, but she then remembered that she was getting WhatsApp messages during her pregnancy from Mom Connect. And they recently just had shared that they also integrate a symptom checker that she can use to assess her symptoms. So she does. And it tells her to seek care immediately. And when she does, she gets diagnosed with tuberculosis and put on treatment right away. This is just one of many stories that I can tell you about someone using a symptom assessment as part of Mom Connect, which is South Africa's government-led maternal health platform, organized by the local organization Reach Digital Health. They send stage-based WhatsApp messages to pregnant women and young mothers in South Africa to support them on their journey. And we integrated a symptom assessment because they got so many messages about people asking about their symptoms that they wanted to provide personalized guidance for their users. And we then ran a decentralized clinical trial to understand the effect of the advice on user behavior. And the data told a really powerful story. From the nearly 1,000 participants, nearly 50% changed their behavior after seeing the advice. Initially, only 17% of users wanted to seek care. That went up to 43%. And this is not just more people seeking care, it's actually the right people seeking care. We sent those cases to a local physician panel, and they assessed that not only safety increases, which one would assume, but actually the behavior was much more appropriate. And what I personally found really interesting was that half of those who received treatment thought they could manage their symptoms at home on their own. And if you look at those cases individually, you really see the impact, because these are patients newly diagnosed with meningitis, threatening miscarriages, sexually transmitted diseases, vitamin deficiencies, and a lot of women diagnosed with hypertension during pregnancy. And early identification is crucial so that complications don't exist. So we learned a lot of lessons throughout this collaboration. And I used the social media format to keep our toss. And one thing we learned that we should keep is to integrate into familiar low data platforms like messenger services. Data can be really expensive in many regions in the world. And even if an application is for free, it is still out of reach for many people. But if you integrate into services that people already use, that they're familiar with using, and that don't cost much data, it's going to be much easier for people to access it. Another one is to continuously adapt and test for local relevance. Many medical devices are initially designed for a very different context. But if you want to provide value in low resource settings, it has to be easy to navigate. It has to be locally relevant information that you share. It has to be available in the local languages and also for the right health literacy level. Large language models are great to assist with this if you combine it with continuous user testing and local input. Okay, so what to toss? Toss the idea of building standalone applications or programs. It is really hard to scale if you have no existing user base in the country. But what really works is if you partner with a program that is already scaled and you solve a problem together. You just skip the uphill climb and just build on what's already working. And the last one is don't skip early engagement with stakeholders. Trust in healthcare is so important, especially if you want to change people's behavior. And we conducted phone interviews with users in South Africa, and they said they trusted information most when it came from the governments or the healthcare providers. It doesn't only have to be about integrating into their service, but it's also a lot about recommendation by them. All right, that is already everything from me. I want to thank the partners at Reach Digital Health, the National Department of Health in South Africa, and my colleagues at Ada Health. If you have any questions, you can find Carol and myself if you want to exchange some learnings. If you're interested in integrating symptom assessments into your organization, also please come and reach out.
Thank you so much, Fabienne, and thank you for sharing all these lessons learned and recommendations. Now we welcome Chandana, Dr. Chandana Unitan, Chief Scientific Officer at LifeGuard Digital Health. She will present a solution pitch on impactful digital health solutions for preventing a public health emergency. Chandana, the floor is yours.
Hello, friends. Thank you for this opportunity to be present here. This is my second time at the Geneva Digital Health Hub. Last year, I had the privilege of putting this across to you when it was, at the time, we had saved 100 lives through this project. Today, we are at a different stage after scaling up. So I just wanted to go back a bit. This is a story of a public health emergency, which is commonly known as the overdose crisis across the world. It is affecting, let's put it that way, being an emergency trained physician and a public health professional, I'm very passionate about this essentially because it's affecting the next generation, a whole youth mental health. Across the world, this is becoming declared as a public health emergency in many countries. So I started off, I'm from Australia, but I was working in Canada for 5-6 years when this emergency was declared. And the solution was born out of that. We worked with the emergency services in creating a digital health solution, which is known as a LifeGuard. It was launched during pandemic when there were 52% overdose deaths as compared to COVID at that time. And we managed over a period of time 100 lives is what we tracked, but there's a lot more lives saved and prevented at that time. So this was the solution that we started off with, which is now in the 6th version. What it does, it is a self-driven app that connects to emergency services should you overdose and have an emergency. So there are the various methods of doing this, and I'm sure that there are people who have, it's a sensitive area, so how do we protect identities? How do we do this? All of this has been worked out through a direct connections, through blockchain technology and other digital methods, which actually hides identities at the same time gets emergency in the country. So we work closely with the emergency services such as 911, 000 in any country. So at the moment, this solution is now being, it's across Canada, and it's being launched in 2 other countries, including Australia. So this is where we are at this point. At this stage, being a prevention-oriented position, so I looked at what are the other ways in which we can scale this, because there is a certain reluctance when it is going out into a general public. We cannot really trace. If you have an app on your with you, does not mean that you are you're going to overdose. So it could be just out of curiosity. It could be a physician. So we looked at what are the ways in which people can use it, and out of that, the vertical segmentation of this was born. And this is for 2 of the options that we have at the moment. One is aimed at only construction industry workers, which is very common in this category. And the other, which is the most important one at this point, is in many countries, drug crisis is also, there is post-incarceration, and people come out of post-incarceration and they still go back to overdosing themselves. And to prevent this, we sort of said maybe we can wean people away from this crisis rather than trying to treat or prevent the overdose. Yes, we do need to prevent the overdose, but we can wean people away gently at the same time by looking at their needs. And that's how the 3rd version was born for people who are post-incarceration. While it does have a certain level of overdose protection, it offers other options so that people do not go back to their addictions. Despite all of these, we had a challenge. This is a SaaS-based or software as a SaaS-based solution. We then looked at social housing and prevention strategies in social housing, and that's where this hardware device was born, which sits similar to any kind of emergency service. It's a device that you can push, and someone in a building or a peer will be notified for that emergency so that they can get medical assistance. In the latest model, we also have some sensors, which actually sits there where if someone has overdosed and has an emergency, it automatically, after some time, it actually senses and sends a message to the emergency services so that they can get a medical assistance. Now, between these 3 together, we have, these sensors are also available for public toilets and in similar areas where this is apparent. So at the moment, we have a presence in Canada, in the United States, in many of the states, Australia, and soon to be in Europe through Austria. So this is where we are at, and we're at the moment scaling. I would, this is a question of looking at from my passion. This is more about preventing an emergency rather than saving people from an overdose, and trying to get people away from it, being from an Australian perspective, prevention is better than cure. So that's what I'm looking at, and any of you who are interested in this area, please come and join us, because we're looking for people who are interested, and also looking at the next generation of people who are going through a big mental health crisis, which is almost a national crisis in many countries, particularly after the pandemic. So where we are at now is 230 lives saved. I mean, I'm not saying this as a complete thing. This is what we have tracked. We can only track this when different countries and emergency services give us the data, because we do not collect that data as a regulation. So this is according to the regulation. Now we are actually going into tracking methods where we can actually track this data so that we can actually prove the use case. Thank you for the opportunity.
Thank you, Sadhana. Thank you very much. And so to finish this session, just before the coffee break, we will now move to the shorter project speed dating pitches that will be introduced by Jérôme Mas, who is the Director Access to Care Technology and Partnerships at Philips. So welcome, Jérôme, and tell us more about these speed datings.
Thank you. And great to be here. Good morning. I know we're running over time, but good morning. Ah, you're still there. Thanks. Great, because this is meant to be an interactive session. So thank you. My name is indeed Jeroen Maas, working as a Director Access to Care at Philips. But here I'm for the Digital Connected Care Coalition. The Digital Connected Care Coalition is a member-driven organization, and we scale digital health projects on the ground. Sorry, I'll stay here. We scale digital health projects on. Thank you. I'm a bit mobile all the time. So it's actually the action that sets us apart from others. And that's why we wanted to interact with the Geneva Digital Health Hub and do this interactive session on 9 very promising pitches. Don't worry, only 3 to start with, and then you can go to coffee. There is a task for you here. So after 3 minutes, I'll have a timer, and you help me clap so that people know that time is up and the next one can come. So we can all go to coffee faster. But also for you, we want your attention because they follow the same format, all the pitches. First, so what's the problem? What do you do to solve it? What is your offer to the audience? So you get 3 offers now in the next 10 minutes. And then, of course, the next question is, what do you ask from the audience? So you don't have to say it straight away. After the pitches, the pitchers will go to the left corner, straight ahead, and the right corner of the room, and you can go there to talk to them. Any questions? You want to go to coffee? But we have very energetic pitches. So can I please have the first pitcher to the front? Mom Care by Femke Hedema from Farm Access. Femke, floor is yours.
Good morning, everyone. I would like to start off with a question. Do you know where you were born? I assume that most of you were born in a maternity ward with a private room, abundant technology, probably a lot of medical personnel. But as you all know, this is not reality for everyone. I remember visiting a maternity ward in Ghana, which was overcrowded, where women were on the floor, giving birth in a pool of their own blood. And that stark contrast, the place where you were born determining the quality of care you receive, is a persistent and unacceptable problem. Every day, 700 women die from preventable causes related to pregnancy and childbirth. 90% of these deaths happen in low and middle income countries. And you heard that, preventable. Lack of coordination across the care system creates fragmentation. Patients get lost, risks are missed, services focus on volumes instead of outcomes. The result, complications that endanger both the mother and the baby. So, what if we could change that, right? What if digital tools couldn't just digitize care, but they could coordinate care around the woman's needs? Connecting patients, providers, and payers across the full maternal journey. That's the vision behind Mom Care. Mom Care has built in Kenya and Tanzania a connected digital maternal care journey. to enable value-based care. Since 2017, we have reached over 60,000 mothers, improving continuity and quality of care, increasing antenatal visits and reducing complications. But we want to go further, and we can't do it alone. To scale beyond our own program, we have developed the MomCare Connected Care Stack, a free, open-source digital foundation designed specifically for maternity care in low-resource setting. At its core is an interoperability layer that enables real-time, standards-based data exchange, and it supports integration of health data across the network, patient engagement through WhatsApp, dashboards to monitor care quality, and AI-driven solutions. It's modular, it's adaptable, and it's built to connect with national systems or be tailored to local realities. I'm here to invite you to use it, to build your own patient-centered care journeys, to share feedback, improve it, and grow a community of solutions that deliver better care for all. Everyone deserves to be born into a system that delivers quality of care. The Connected Care Stack is just the start. Let's use it to transform maternal health together.
Well done, well done. We made a promise to the audience. So second pitch that we will have now from Thomas Lamp will be as strict as we were with the first one. So Thomas, the floor is yours.
Perfect. Thank you very much. Hi, everyone. My name is Thomas. I'm the co-founder of a company called Upleap. We're a spin-off of ETH Zurich and the University Hospital in Zurich. And what we're trying to do is integrate medical training into everyday practice of healthcare professionals. So why medical training? One of the medical doctors that we're working with here in Switzerland, keep that in mind, once told me, if I ever get sick, I have my own blacklist of medical doctors that I do not want to treat me. And well, I find that a little bit concerning. So I dug deeper. And numbers show that 40 to 50% of medical professionals are not really confident or not really comfortable in treating or in their everyday practice. So that's also quite a huge number, I thought. So I dug deeper. And the WHO says 8.2 million people die every year because of preventable medical issues which relate to training. So medical training is indeed important, but what's the issue there? So current medical training is often very much ancient, I would say. So there's a classroom lectures, I think everybody knows that, very theoretical, not really applied. E-learning, you know, these PDFs, and then you answer 5 quizzes, half an hour, sit in front of the laptop. Also not very applied. And then you have training courses where people go once a year, once every 2 years. So they're not very frequent, they're super expensive, and there's very little in between. So this is what we're trying to do with Upleap. We provide an AI-driven platform that provides scenario-based, short, practical medical trainings that are integrated into doctors' everyday work. We call it like a Duolingo for medical. If you've used Duolingo, you know the principle, right? Instead of doing like a one-day course, you do it like 5 minutes every day. So this continuous repetition makes it work. So it's a mobile-first approach. It's an app-based approach. It's due to that very much scalable, hands-on, and context-specific. And we're piloting that at the moment around 8 countries, including South Africa, Kenya, Zambia, which is also where you see this picture here. So that was taken by my colleague Leonie last year in Zambia. And this is how you see how it works. So the app basically provides guidance to medical professionals to go through interactive scenarios, either by themselves or in teams, as you see it here. So none of them is a medical trainer, but what they do is basically they guide each other through that medical training, and in the end they discuss and they get guidance by the app. And that's a great success. So they're currently rolling that out, or we're rolling it out together with SolidarMed in 50 different hospitals, and hope to expand that. So basically what we expect to be the outcome or the impact of this is, of course, you get improved clinical confidence, onboarding procedures go much easier. You hopefully reduce the preventable medical errors, and healthcare professionals are the backbone of the healthcare systems. So if you support them in their daily work, you strengthen healthcare systems themselves. So what we offer is our AI-driven platform. It's live, it's open, either for individuals or for teams. We have preloaded scenarios, but also, as I said, we use AI to generate customized scenarios. So all the trainings are very much individualized to the specific areas. And we invite everyone to, time is running out, but we invite everyone to join us. So if you want to test it, happy to talk afterwards. Thank you.
Thank you, Thomas. Thank you. So Thomas will be at the back of the room afterwards. And then we go to our third and last pitch of this round, which is by Matt Riley of Philips.
I can use this, Ewan. Hi, everybody. Good morning. It's an absolute pleasure to be here and to follow on from all of these amazing presentations and digital innovations. And hopefully I can continue that theme here. So my name is Matthew Riley. I'm from Philips Ultrasound, and I'd like to talk to you about Smart Sweep, or the project where we're using AI to enable simple assessment of fetal well-being. So I'm sure all of you know that ultrasound is standard of care for antenatal obstetrics. And we have, amongst many other companies, handheld ultrasound machines. Now, that is an amazing innovation and really allows access to care, but in itself is not sufficient. The problem with ultrasound, and I can say this, clearly I've been doing ultrasound for 30 years almost, is that it's operator dependent, and it requires training to both acquire the image and interpret the image. You can see up here, I think it's on your left-hand side, the small image shows a typical ultrasound image. And that actually is an image of a fetal abdomen. Now, what we're trying to do is address that problem. So what we've taken is a series of AI tools that will support the acquisition through simple guidance and audible feedback, and interpret the image so that we can get a very simplistic overview of the fetal position, but also some key parameters that help assess fetal conditions. So what we anticipate is that we'll be able to increase access to quality care, improve the identification of higher risk pregnancies, and support the correct maternal pathway, more confident decision-making at the point of care by frontline healthcare workers, and importantly, remove the barrier of training. So what we've found is that these AI tools can reduce the training time. Typically, for ultrasound, it can be months, sometimes years in the US, to just 1 or 2 hours. So our offer is an AI-supported tool that will support fetal assessment at the point of care in low and middle income countries, tailored for those environments, because we've worked in Kenya, worked in India, we've got data from 3 continents from over thousands of pregnancies, and we're able to deliver a sustainable, high quality maternal ecosystems across the globe. Particularly today, what am I looking for? I'm looking for your feedback, and I'm looking for your help, because what we want to do is scale this solution across the globe in an effective manner. Thank you all very much.
Thank you, Matt. Thank you, Thomas. Thank you, Femke. 3 fantastic pitches, and I'll keep it very short. The second round will be done by my DCCC colleague, Charlotte. She'll be presenting a second round. Now I'll give it back to the organizers. Thanks for your attention.
Thank you.
Thank you so much, Johan. And thank you very much to all the speakers for sharing all this very interesting learning. It was really an exemplar of digital health, and I hope you enjoyed the session as much as I am. For me, I think the key learning is something that Smisha said at the beginning, that all these projects that have scaled, they have building blocks of experimentation, years of experimentation, testing, sharing, and I think it's very valuable that we heard all about this project today so that we can learn from them. So let's give a big round of applause for all the speakers because they deserve it.
Yes, and Thank you everyone for attending this session. For your information, we are almost 300 in this room, and there are also people online. So thank you to people that are following online. There are more than 200, 220, 30. So we are more than 500 following these speeches. So this is quite impressive. I think we can applaud that too. And now, so we have a small coffee break of around 15 minutes. We will try to begin the next session around 11:15. So if you want coffee or walk a little, there are something in the forum just here. Thank you very much, everyone.